Hello again. So I'm going to be presenting on early ileostomy closure following ileal-pouch anal anastomosis for ulcerative colitis. These are the disclosures for the authors. So just some background. In patients with ulcerative colitis, typically they undergo an ileal-pouch anal anastomosis, also known as a J-pouch. And typically this is constructed as part of a 3-stage procedure with a diverting loop ileostomy as part of the second stage. This diverting loop ileostomy is then closed about 8 to 12 weeks post-operatively as part of the third stage. But the diverting loop ileostomy is associated with some significant morbidity, including dehydration, ileus, high ileostomy output, as well as obstruction. There's been some data in rectal cancer that has shown that early diverting loop ileostomy closure, typically within 2 weeks following LAR for rectal cancer, has resulted in fewer postoperative complications as well as fewer stoma-related complications when compared to a delayed closure, which is after 12 weeks. And this randomized controlled trial also showed no difference in the rate of major complications. There is very limited data on early ileostomy closure following J-pouch. So our hypothesis was that patients who undergo early loop ileostomy closure following a J-pouch for UC would have fewer overall complications as well as ileostomy-related complications compared to patients undergoing the traditional loop ileostomy closure at 8 to 12 weeks. And our aim was to analyze our institution's cohort of 3-stage IPAA for ulcerative colitis and compare postoperative outcomes based on the time of the loop ileostomy closure. So the methods, this was a retrospective analysis of all ulcerative colitis patients that underwent loop ileostomy reversal within 12 weeks of their 3-staged planned IPAA, and this was at a high-volume, single-center, tertiary referral center. Patients we had classified as either going early reversal, which we had defined as less than 4 weeks, mid-timed reversal, 4 to 8 weeks, or late reversal, 8 to 12 weeks, which is the traditional closure time. The standard of practice at our institution is to close at 8 to 12 weeks following radiographic confirmation of no anastomotic complication, typically with a barium enema. And the patients who ended up undergoing early reversal within this cohort typically had other factors that prompted the early reversal, such as high ileostomy output, multiple readmissions, or obstruction. We analyzed patient demographics as well as postoperative outcomes, such as readmissions, reoperations, and the overall rate of complications, and we used the Clavian-Dindo classification for complications. So between 2008 and 2020, we had 304 patients who underwent a 3-stage IPAA for ulcerative colitis. Within our early reversal group, we had 15 patients, which made up about 5%, with the median time to reversal of 3.6 weeks. The mid group had 109 patients, about 36%, and the late group had about 60% of the patients, median time for those being 6.4 weeks and 10 weeks respectively. We didn't find any preoperative differences in age, sex, or BMI between the groups. And then postoperative outcomes following their second stage, the second stage being the creation of the J-pouch with the creation of the diverting loop ileostomy. Overall, the rate of postoperative complications was 42%, and the rate of ileostomy-related complications was 36%. The overall rate of admission following this second stage was about 23%, and 20% of those were related to ileostomy issues. So patients within our early reversal group, they were more likely to experience ileostomy-related complications. They had an 80% rate of complications compared to about 1/3 for the other groups, and they also had higher rates of readmission. Again, this is not unexpected because these groups were reversed early because of these complications. These patients were also more likely to be reversed during one of these readmissions rather than undergo an elective reversal. So overall, the postoperative morbidity was 36%. This did not differ between the 3 groups, and our rate of major complications did not differ between the 3 groups as well. We had a low rate of anastomotic complications, and we also had a low rate of reoperations amongst the 3 groups. There was a longer length of hospital stay among the patients who underwent the early ileostomy reversal, but we found no difference in readmissions following that reversal. So in conclusion, although an early small subset of patients underwent early ileostomy closure following their J-pouch, we found that there was not a significant increase in the rate of overall complications, anastomotic issues, readmissions, or reoperations. And most of these early reversals were prompted due to ileostomy-related complications. And based on this data, further research can be conducted to explore elective reversal of elective early ileostomy reversal following J-pouch, which might have effects on overall outcomes as well as patient quality of life. Thank you.